Welcome to this explainer. Today, we're going to do something really important. We're going to teach you how to decode addiction. We're looking at the exact clinical framework of substance use disorders. We're going to strip away the casual, everyday usage of the word addiction and dive straight into the hard medical science. We'll explore exactly how clinicians define, diagnose, and treat these incredibly complex conditions. So let's just jump right in.
Here's our quick roadmap for today. First, we'll be defining the disorder, then looking at the core clusters, uncovering the roots of addiction, shining a spotlight on alcohol, and finally discussing treatment.
All right, part 1, defining the disorder and the big DSM-5 shift.
So, there's actually been a massive fundamental shift in how psychology looks at addiction. Back in the day, clinicians used to sort these problems into two totally separate buckets, right? You had substance abuse over here and substance dependence over there. It was a very rigid black and white way of thinking. But under the current DSM-5 standard, which is basically the clinical rulebook, the medical community completely threw out those separate categories. Instead, they replaced them with a single-dimensional diagnosis called substance use disorder, or SUD for short. Now, it's rated on a sliding spectrum. It can be mild, moderate, or severe, depending on a specific symptom count. It's honestly a much more precise and unified way to look at the whole picture.
Now, to really grasp the spectrum, we've got to define some key pharmacological terms, and we're going to teach you 3 big ones today. First up is tolerance. Now, this isn't just about, behavioral endurance or having a high tolerance in a casual sense. Tolerance is a very real physiological adaptation. Your body literally adjusts its baseline. Because of this structural change, you suddenly need increasing amounts of the substance just to achieve that exact same original effect. Basically, your brain and your body are physically changing how they operate.
And hey, that physiological change we just talked about, it leads directly to our second crucial definition, withdrawal. This usually kicks in after heavy or prolonged use when the substance is suddenly taken away. It's a highly specific cluster of physical and psychological symptoms that just kind of crash over the patient the moment the concentration of that substance in their blood or tissue starts dropping. Remember, the body has completely adapted to functioning with the substance, so without it, the body is thrown into a state of severe turbulence.
Finally, we have intoxication. This is the temporary state most people immediately think of when they think about someone using a substance. It is a completely reversible, substance-specific syndrome that comes directly from recent ingestion. But the key takeaway here is that unlike the deep structural adaptations of tolerance or withdrawal, intoxication is just a temporary state. It wears off.
Moving right along to Section 2, the core diagnostic clusters, specifically the 11 DSM-5 criteria.
So how does a clinician actually diagnose substance use disorder? Well, the DSM-5 uses 11 criteria that are neatly organized into 4 major life clusters. Cluster 1 is impaired control. Think of this as using way more of a substance than you intended, spending huge chunks of your day trying to get it, or just dealing with intense, overpowering cravings. Cluster 2 is social impairment. This is where the disorder starts destroying major obligations at work or school, or causing severe friction in your relationships. Cluster 3 is risky use, which means repeatedly using the substance in physically dangerous situations. And finally, Cluster 4 contains those pharmacological criteria we literally just talked about: tolerance and withdrawal. Okay, part 3, the roots of addiction. Why does it actually happen?
Any good clinician will teach you that the root of addiction is never just one single thing. It relies on what we call the biopsychosocial model. It's like a giant puzzle. Biologically, your genetics play a massive vulnerability role. And crucially, almost all addictive substances literally hijack the brain's dopaminergic mesolimbic reward pathway, basically the brain's feel-good center. Psychologically, people might use substances to numb negative feelings, or they might be chasing the positive reinforcement of euphoria. There are even expectancy effects, meaning a person's belief about what a substance will do actually shapes how they use it. And socially, the environment is a huge catalyst. Things like peer pressure, family modeling, poverty, and chronic stress all deeply influence vulnerability. Put it all together, and it's a perfect storm.
Let's get specific in Section 4, a spotlight on alcohol use disorder.
To really understand this, let's look at alcohol, which biologically acts as a central nervous system depressant. Its effects follow a very clear step-by-step dose-response curve. At low doses, step 1, it produces mild relaxation and disinhibition. You let your guard down a bit. But as that dose increases, it starts depressing the central nervous system even further. We're talking heavily impaired coordination, judgment, and speech. And at very high doses,
it becomes a genuine medical emergency. There is a severe risk of respiratory depression, which is where the body literally forgets to breathe, and that can tragically lead to death.
And the danger doesn't stop when the drinking stops. When a chronic heavy drinker quits, withdrawal is incredibly dangerous. Just hours after their last drink, a mild to moderate phase kicks in. We're talking intense anxiety, tremors, sweating, and a really elevated heart rate. But the scary part? Roughly 2 to 4 days after quitting, heavy drinkers can face a severe medical emergency. They can suffer from withdrawal seizures and something called delirium tremens, or DTs. This involves severe confusion, massive bodily instability, and honestly, terrifyingly vivid hallucinations.
Beyond that immediate withdrawal, the long-term physical toll of chronic alcohol use disorder is just devastating. One of the most fascinating and really tragic associated conditions is Wernicke-Korsakoff syndrome. This actually comes from a severe thiamine or vitamin B1 deficiency that is caused directly by chronic drinking. It leads to confusion, loss of muscle coordination, and a profound memory impairment where the patient engages in confabulation. That's a fancy way of saying their brain essentially makes up stories to fill in the missing gaps in their memory. On top of that, chronic use ravages the liver, progressing from a fatty liver to cirrhosis. And of course, prenatal exposure can result in lifelong fetal alcohol spectrum disorders.
Finally, Section 5, Treatment and Paths to Recovery.
Because of those severe risks we just talked about, like delirium tremens, quitting a severe alcohol dependence cold turkey isn't just difficult, it is genuinely life-threatening. That is exactly why medically supervised detoxification is the absolute essential first step. In a medical setting, clinicians will carefully use medications like benzodiazepines. Why? Well, because alcohol and benzodiazepines interact with your nervous system in somewhat similar ways, so the benzos can safely manage those severe withdrawal symptoms and, crucially, prevent those fatal withdrawal seizures we mentioned earlier. But detox is just the beginning. Once that's complete, long-term treatment requires a really strong, multi-pronged approach. On the pharmacological side, medications are used to literally alter the body's reaction to alcohol. A drug called disulfiram can cause a severe physical aversion if you drink, which really deters use. Naltrexone is used to reduce cravings and actually block the neurological reward of drinking, while acampressate helps calm those lingering post-withdrawal cravings. But here's the thing, medications alone just aren't enough. They have to be paired with vital psychosocial therapies. Clinicians will use motivational interviewing to help build a patient's internal drive, cognitive behavioral therapy for highly specific relapse prevention strategies, and 12-step groups like AA to provide ongoing peer-driven social support. It's the whole shebang working together that yields the highest chance of long-term recovery.
So, we've covered a lot today. We've moved from those outdated definitions to the dimensional DSM-5 spectrum. And we've mapped out the biological, psychological, and social roots of substance use disorders. Understanding the true medical reality behind addiction is absolutely crucial, and I hope we were able to teach you a fresh perspective today. I want to leave you with this final thought. How might society's view of addiction, and the intense stigma surrounding it, shift if everyone truly understood it through this purely clinical, biopsychosocial lens? Something to chew on. Thanks so much for joining this explainer, and keep exploring the fascinating world of psychology.